Okay, Lynette, I'm showing 9 o'clock. So
Okay.
I think we can go ahead and get started. I want to welcome everyone to the meeting this morning of our Care Management Committee and call the meeting to order. Thank everyone for attending. We do not have minutes to approve as we've not met in some time. But we do want to just kind of go over, before we get into our agenda, or first couple items of our agenda, or a couple housekeeping things. We wanted to, since it's been a little while that the Care Management Committee met, Lynette and I thought it would be helpful to review the purpose and role of this committee, to kind of refamiliarize ourselves with the type of activity that we will be reviewing, how we can assist. So at this point, Lynette, if you could please share that information with us.
Sure, absolutely. And thank you, Mr. Williamson. Good morning. And good morning to the members of the committee and those that are also attending and observing this morning. So as Mr. Williamson indicated, it's been a while since this committee has met, and per the request of Chairman Boyd, we are reinstituting the committee meetings. And so just want to take a little bit of time to talk about the purpose and the role of the committee. I think first and foremost, one of the reasons why Chairman Boyd wanted to reinstitute this particular committee was to make sure that we were reporting out to the board on the various initiatives that we are moving forward, and to provide updates on the major program changes that we are putting into place. Typically in our regular board meetings, we present certain items for board approval. Those things tend to relate to changes in methodology for certain procedures or policies, but they don't really get into a lot of the initiatives that we are working on as an agency. And so we thought this committee would be the appropriate place and the appropriate venue in which to share those updates. And so that's the first thing, is just making sure that the department is going to provide those updates to the committee. And then I think second, in terms of what we would like for the committee to do, overall is to help to improve performance and outcomes. And so that could come to us through recommendations or suggestions from the committee. If there is something that you all are hearing out in the community, in the provider community, by all means, bring those back to us for your recommendations, and we'll take those back for, analysis and review. The one distinction I did want to make this morning, Mr. Williamson, is that we do, per federal regulations, have an advisory committee. It's the Medical Care Advisory Committee. That committee does fall under Dr. Holloway's purview. So one of the things that we wanted to ensure is that, we're clear that that is a separate and distinct committee from this one. The Medical Care Advisory Committee is an advisory board, so their role and their authority is different from this committee. This committee would more so, provide, recommendations or your thoughts or concerns, and then we could take those back and vet them through our advisory committee. That would be the approach that we would take, and then report back out to this committee on, those recommendations and the ultimate decision of the advisory committee. So that's how we would proceed with any recommendations that we receive from this group. So I hope that gives, at least from a high level, what our thoughts are in terms of the purpose and the role. I also think it would be helpful if we were to, in advance of the next meeting, perhaps to put together a charter. We were unable to locate one. There may be one, maybe from years and years ago, but we've had changes in personnel and staffing, and so I think it would be helpful as well, Mr. Williamson, if we, develop a charter to kind of guide us going forward.
Agree. So thank you for that, Lynette. Are there any questions about the role of the committee or some of the distinctions that Lynette shared? All right. Thank you for that information. Let's talk about our meeting cadence then.
Yep. In terms of meeting cadence, my recommendation is that we meet quarterly. That would actually align with, at least I know one of the other committees that we have, which is the audit committee. And I think too, it would help to perhaps avoid any conflicts, versus having the meetings on the same day and utilizing the same resources for both. So my recommendation would be on a quarterly basis, and that way that would help to avoid any conflicts. Additionally, in terms of updates, while we have quite a bit going on, things don't tend to move quite that fast. So I think quarterly would be most appropriate in terms of us providing updates to the committee.
I think if I recall, that was the cadence we had initially when we were meeting some time ago. So
yep.
Any feedback from the committee or any concerns with that approach? All right, so hearing none, we will proceed with that recommendation from Lynette to meet quarterly.
Okay. Awesome, great.
So that takes us to, oh, sorry, go ahead, Lynette.
No, go ahead. I was going to shift over to our next topic.
Right, great segue. So now that we've taken care of some of those things, and I do think the charter will kind of put in writing kind of some of the things that you talked about, just so we've got that to refer to. But let's move to our first presentation, which is the Peach State WellCare integration.
Sure, and so I'll kick us off there. So wanted to just give a verbal update on where we are and what has happened with respect to the Peach State WellCare integration and merger. So no slides on that today, but more so just a verbal update. I'll start off just by kind of going back to July of 2017. As I'm sure most of the attendees and committee members know, on July 1 of 2017, we renewed our care management organization contracts, and we had 4 care management organizations in Georgia. They were AmeriGroup, CareSource, Peach State Health Plan, and WellCare. Peach State and WellCare were 2 of our largest managed care organizations and really have been since the inception of the managed care program back in 2006. And so in January of 2020, Centene, which is the parent company of Peach State Health Plan, announced publicly their intent to acquire WellCare. So this was actually an acquisition. I know we referred to it as merger, but this was actually an acquisition that took place whereby Centene purchased and acquired WellCare. So beginning in January of 2020, once that announcement came out, and actually a little bit before, we began working with both Peach State and WellCare on the integration. And so there were, as you can imagine, a lot of eyes on this particular acquisition, and that's because they're 2 very large managed care organizations. So we had quite a few discussions with our Department of Insurance here in Georgia, We met multiple times with the Department of Justice as well as the Security Exchange Commission to talk about the impacts of the merger or the integration in the state of Georgia. So we wanted to make sure that, things rolled out correctly, that we had all of the legal authorizations in place. And so once all of those were aligned and in place and, we had documentation, then we started moving forward with the actual integration. And so there was quite a bit of work that went into this for the committee members. And I want to talk about some of those things this morning. So first was the transition of members. As you can imagine, that was a huge area of concern for us. We wanted to make sure that once the members transitioned over to Peach State Health Plan, that we could ensure continuity of care. First and foremost, we did not want anyone to fall through the cracks. So we spent quite a bit of time in that area. We worked with both of the plans on care coordination and case management. We talked about how we were going to handle existing prior authorizations. So as you can imagine, we had members who had open prior authorizations that were enrolled with WellCare. And so once those individuals transitioned over, we wanted to make sure that they were still able to receive those services and that there would be no interruptions. And so what we agreed upon was to honor any open prior authorizations for at least a window of 60 days. So that would help to ensure continuity of care. We spent quite a bit of time looking at pharmacy prescriptions because as you all know, our CMOs all have different pharmacy drug listings. And so one of the areas of concern was, well, what would happen if there were a WellCare member who had a prescription for a particular medication that was not covered by Peach State Health Plan? How are we going to handle that? So we took that same approach, which was that Peach State would honor any open prior authorizations for pharmacy medications for 60 days. And that would allow them to, during that 60-day window, interact with the physician, the prescribing physician, and the member and the pharmacy to see if they could continue to accommodate that beyond 60 days or if changes needed to be made. So overall, that went very well. We spent a bit of time looking at members who were under what we call a pharmacy lock-in. So these are members who have a history of, abuse in certain areas. So we wanted to make sure that we still kept a pulse on who those individuals were, and we wanted to make sure that they were still going to remain under the pharmacy lock-in program. Discharge planning was another big area because we knew that as a part of this integration, there were going to be some members who were in an inpatient status once this transition happened. So we wanted to make sure that we knew who those individuals were and that we were ensuring adequate and appropriate discharge planning was taking place. We worked on processes and procedures going forward for utilization management, disease management, and we also spent a significant amount of time on member communications and materials. So we needed to make sure that the WellCare members who were going to be transitioning over to Peach State were well aware of what was going to occur, what dates the transitions were going to take place, things like the prior authorizations, how those were going to be handled. So a lot of work went into the transition of members, that component. We spent also a lot of time on provider network. And so what we started out doing at the very beginning was to compare both networks. So WellCare had their provider network, Peach State Health Plan had their network. And so we did a comparison of both networks to see, did WellCare have providers who were not contracted with Peach State Health Plan? So that was step number one. And so for those providers who were not in Peach State's network, we did outreach to those providers and informed them of the transition and the fact that the members that they were serving were most likely going to transition over to Peach State and that we needed to get them in the network. So Peach State sent out notices to those providers informing them about the upcoming integration and merger and invited them to the table for, negotiation and contracting purposes. There were some
Hey, Lynette, can I just interject for
Yes.
a moment on that
Absolutely.
particular item? Did most of the physicians who were not in Peach State prior but were in WellCare, did they agree to become in network with Peach State, or how did that go?
Yep. Great question. Most of them signed up. Most of them signed up. There were a few, and this, this happens. There were some providers who did not want to contract with Peach State Health Plan, and that's understandable. That's their right. But the majority of them did, in fact, agree to contract with Peach State Health Plan. So that was good news for us. And for those that did not, what we required Peach State to do was to continue to work with those providers, even if it was in an out-of-network relationship, or in some instances we may have had to do a single case agreement. But Peach State continued to work with those providers at least for 60 to 90 days, and thereafter, if we were unable to get that provider in the network, then they were either out of network or we transitioned that member to a different provider.
Thank you.
Yep. There were some contracts that were renegotiated. Those were mostly some of the larger hospital systems. So I do know that Peach State, had to go to the table on some of those contracts and renegotiate. And then ultimately, right before the integration took place, we did have to do a geo-access review or a network analysis review to ensure that the network would be sufficient to accommodate the members that Peach State Health Plan was going to gain through this acquisition. And so that proved successful and all went well in that area. So a lot of work done, as it relates to provider contracting. The third area that we focused on was their call center operations, because as you can imagine, they were picking up a significant, they being Peach State, were picking up and gaining a significant amount of members. And so we needed to make sure that their call center would be able to handle the increased volume of calls, which we did see immediately after the integration. Their volume did increase significantly. So we wanted to make sure that they had the capacity in their call center and that they had adequate staffing. So lots of work done in that area. We also focused on systems integration. And there, really the focus was on ensuring that they would have the ability to process and pay an increased volume of claims. And so once you start transitioning members and providers over to Peach State Health Plan, you have to look at the fact that the volume of claims coming through Peach State's system was going to increase significantly. So a lot of work and testing done in that area And I'm pleased to report that we didn't have any issues in terms of processing or payment of claims, that were related to the integration. We also looked at staffing. So when you have an acquisition, staffing is always going to be an area of concern. And so, which employees were going to transition over, which were not. We had 2 CEOs, so, that was addressed early on in terms of which CEO would remain. We had a number of key staff that we needed to ensure were going to be in place. And so we required Peach State Health Plan to submit to us an updated org chart. And so we reviewed that org chart to ensure that the staffing was going to be adequate for administrative staff as well as their clinical staff. So, from the clinical perspective, we're looking at their medical directors, nursing staff, their behavioral health teams. And so all looked well there, so there were no issues. And additionally, as it relates to staffing, we had to focus on employee training. And the initial thought may be, well, why did you have to train them? Well, for 2 reasons. They were moving from one health plan to another. So you had employees that needed to be trained on Peach State's internal systems, their computer systems. And additionally, there are some differences in the benefit structure. So you have your baseline Medicaid services that all of the managed care entities have to provide, but you also have value-added benefits, which go above and beyond. And so we needed to make sure that the staff were trained and familiar with Peach State benefits. And so that went well. We focused on quality improvement and performance measures. Dr. Holloway's team was integral with that, and making sure that from a quality standpoint that we were in a good position. And then lastly, we focused on facility operations. And there we were looking to ensure that they had put in place precautions and safety measures for COVID-19. So quite a few questions, we had for them in that area, but we were satisfied that they had met all of those safety requirements. So overall, it went very well. In January of 2021, so we're talking about a year after the announcement of the acquisition, we conducted a readiness review. And that readiness review took place over a period of 5 days. And so we reviewed all of those areas that I just touched upon with Peach State staff and the DCH team all at the table, or I shouldn't say table, it was virtual, but all on Zoom, to make sure that we had resolved any deficiencies or any areas of concern, and that we had conducted and allowed time for adequate follow-up. So that readiness review took place the last week of January. In February, we sent a notice to all of the WellCare members, and that's February of this year. We sent a notice to all of the WellCare members regarding the May 1st integration, because that was the date that we had agreed upon that we were going to allow the shift or integration to take place. So we sent a formal notice out to all of WellCare's members, since they were going to be the individuals impacted. And in that notice, we allowed them and informed them of the option to select a new CMO. And so we weren't going to just force them to go over to Peach State. We allowed them the opportunity to change to a different health plan if they chose to do so. And so those WellCare members had a period of 30 days, and that were actually 31. It was the full month of March, in which to select a new health plan. And so we had about 50,000 members, which was relatively small, about 50,000 members select to move to a different health plan. And then those that did not select a new health plan were automatically transitioned over to Peach State on May 1st.
And how many?
What
was that number, Lynette? 50,000 changed. Roughly how many then transitioned the remainder? What was the size of that group?
Yep, it was about 450,000 lives. And I'm going to tell you what the final totals are in just a minute.
Okay.
So quite a few went over. WellCare has always been our largest plan, and they've always had approximately 500,000 members. So if you're looking at only 50,000 that chose to move, that left about 450,000 that transitioned over.
Okay.
Yep. And so on May 1st of this year, the integration took place. It has gone very well. We've received very few complaints or concerns about the integration. It's been very quiet, actually, which is good news. After the May 1st integration took place, we did a post-integration touch point with Peach State. And we did that for over a period of 6 weeks. So starting May 1st, that next week we begin our weekly touch point meetings to ensure that if there were any, issues or concerns, that we would address them together as a team. And so it was exactly in some regards as we had predicted. So the call center metrics, Peach State had to report out to us on that each week. And so the volume spiked just as we had projected it would. And there were things like members calling in, wanting to change their primary care physician, or members wanting to get a new ID card, or maybe they lost the ID card. So there were general, things that we would have expected, a new member of Peach State Health Plan to ask. And so they were well equipped to handle that volume and that spike. So I was pleased that we had done the initial legwork in that area. We also required Peach State to report out to us on the volume of claims that they were receiving in their system, and how many were paid, how many were, denied, how many were rejected. And so we reviewed that with them on a weekly basis. We also received reports from Peach State on the number of members who were in an inpatient status. And so if you will recall, Mr. Williamson, I mentioned that we wanted to make sure that for those members who were in an inpatient status, that discharge planning was occurring appropriately. And so Peach State performed daily rounds internally with their clinical team to review all of those members who were still in an inpatient status, who had transitioned over from WellCare, just to make sure that we knew, where those members were in terms of their inpatient stay. And so that went well. And so all of those were areas that we, focused on during that 6-week post integration May 1st date. And so overall, again, it remained pretty quiet. For those issues that, we did hear about, those were addressed quickly. We continued to keep a pulse on provider contracting as well. And so for those providers who had not completed the contracting process or who had not signed up with Peach State, we asked for updates on who those providers were, how many were there, and the amount was very small, but we wanted to keep a pulse on that as well. And we also monitored prior authorizations. So that's where we landed after the 6 weeks. And so where do we stand today, and what do the numbers look like? so as of August the 1st, our total managed care enrollment is 1.8 million members, and that's spread across now 3 health plans. And the exact amount as of August 1st is 1,816,192 members. In terms of the breakout, Peach State Health Plan, as of August 1st, has a total of 944,000 members. 944,976 members are the exact totals. CareSource, who is still relatively new to Georgia, has 373,000 members. And AmeriGroup has 497,000 members. And so those numbers and those totals are, significant, and they're very large. One thing to keep in mind for the committee is part of that is due to the public health emergency. And so for those of you who may not be aware, as of March of 2020, we are not or have not terminated any members from enrollment. And that's per the CARES Act that was issued. And so there are very, very limited circumstances on which we would terminate a member. Those pretty much would be a situation where someone moves out of state, or they voluntarily terminate membership, or the member is deceased, or they were erroneously enrolled. And so aside from those very limited circumstances, everyone else has remained enrolled in Medicaid and Peach Care for Kids since March of 2020. So that's in part why those numbers, are so large or may seem to some to be inflated. And so we'll continue to abide by that. We'll continue to keep these individuals enrolled until we hear about the next steps for the public health emergency. And so that was just extended on July 19th for another 90 days. And so, we're just keeping a pulse on where we are with the public health emergency. But those are the totals today. So that's the update that I wanted to share as it relates to the Peach State WellCare integration. And I'll pause now for any questions.
Okay, that's a great update. It sounds like there was a lot of planning that went into place once that was announced, and a lot of good work by the department in collaborating with the plans, and then it sounds like the outcome has been has gone extremely well given the size and magnitude of it. But we'll pause. Any questions from the committee?
Anthony, this is Roger. I just want to say, Lynette, that was a great summary and a lot of good information, and thank you for that presentation.
Great. Thank you. And if you guys have any questions, just reach out and we'll provide responses. So that completes the presentation for the Peach State WellCare integration.
Thank you, Roger. And again, thank you, Lynette. Let's now transition to Kelvin Holloway. Dr. Holloway is going to give us an update on our quality strategy. Take it away, Dr. Holloway.
Thank you, Mr. Williamson, and good morning, committee, as well as to others. As mentioned, I am Dr. Kelvin Holloway, and I serve as the lead for the Performance and Care Management Office as a Deputy Executive Director. What I'd like to do is spend a few minutes going over our quality strategy that currently has been submitted to Centers for Medicare and Medicaid for approval. It was submitted in the end of May, and we are waiting for their approval before it to become official. What I'd like to do is to provide that overview first by giving you a little insight in regards to the rationale for developing a quality strategy, as well as updating that, share who the central team members were that facilitated that process, certainly how the quality strategy is built upon the foundation of the department's mission and vision, provide an overview of the strategy framework that everything else hangs upon, and just spend a few minutes speaking to our approach within the quality strategy as relates to desiring to impact health disparities that exist within our beneficiaries within the state. Just share a little insight in regards to how stakeholder feedback was incorporated, and provided a high-level overview of the quality strategy aims, goals, and objectives, and then closing with where we are within that timeline for that project of the developing the strategy and the submission. The CMS Medicaid managed care rule requires managed care Medicaid programs to develop and implement a quality strategy for assessing and improving the quality of healthcare and services for our beneficiaries. That same rule speaks to the need or requirement that that strategy must be updated at least once every 3 years. The most recent one that we were operating under ran through 2020, and the current one that's been submitted will run through 2023. Clearly, the strategy will focus on the state's current and evolving priorities. This is our team. This is our team that led the development of our strategy. Gloria Beecher served as the project lead, and the facilitator did an outstanding job. She serves in the role as Director of Population Health and Quality Planning. Carla Willis, critical and central as far as participating, serving as the Director of Performance, Quality, and Outcomes within the Medical Assistance Plan in the department, and certainly a number of other subject matter experts within the department, as well in some instances sister agencies. And we leveraged resources to assist us in developing the quality strategies that are noted as far as Health Services Advisory Group employees. It goes without saying that any quality strategy is built upon the department's mission and vision, and how we propose achieving those, be it as noted within our strategy. First and foremost, in regards to, as the mission states, to provide access to affordable quality health care, be it for our beneficiaries, and aspirational vision as it relates to promoting the health and prosperity of our citizens, be it by improving their health status. And all of this is foundational onto the values that support DCH's achievement of the vision and the vision. The three overarching aims that are reflected in our quality strategy are noted here: improving the health, services, and experience for our beneficiaries. How are we good steward of our resources? Smarter spending. And we opted to develop a quality strategy that did not just incorporate our beneficiaries that are covered under a healthcare delivery model of managed care, but also to include our fee-for-service population, age, blind, and disabled, as well as our waiver population that's incorporated predominantly in home and community-based services, as well as long-term support services. We wanted our strategy to be holistic for all of our beneficiaries in our plans, and it's to improve the health and services in that population as well. The 3 aims are undergirded by 9 goals, and each one of those has performance measures that DCH will measure and track towards achieving specific goals that are identified. Each goal is tied to specific interventions or programs and tactics that will drive improvement within and across goals and objectives, as well as the interventions that are tied to these tactics that also are tied to metrics that we will track and follow through the course of the strategy. Incorporated in the plan, as I mentioned, is in terms of our approach to addressing health disparities experienced by our beneficiaries. These are the 8 CMS categories of disparities. We certainly developed a roadmap within the plan that in the strategy to impact disparities, once focusing on how we identify them, evaluate, and reduce them. Noted here is just a visualization of that approach in regards to ensuring that addressing health disparities is a strategic priority within the quality strategy, developing a structure that we deem to be a roadmap for success to support addressing health inequities. What are those programs and tactics that will be put in place through our managed care entities and vendors? Understanding the significant impact that social determinants of health have on that. So ensuring that those programs address those determinants of health that are noted. And also understanding the need to develop collaborations and partnerships with stakeholders in the community, as well as collaboration across managed care organizations to truly have impact on healthcare disparities. The framework that we reference, represents really a comprehensive plan for delivering high quality and accessible timely care for our Medicaid beneficiaries, leveraging a number of methods, but it's inclusive of developing and maintaining collaborative strategies and relationships that we referenced, and also in regards to partnering with other state agencies and community resources. Also using other levers, be it in terms of performance improvement projects, performance measures, accountability venues such as this, contract compliance, implementing alternative payment models and evidence-based practices to achieve the desired outcomes, and also IT enhancements, as well as enhancing member services and satisfaction. All of these will be included within our strategies, as well as tactics and programs to ensure that we are advanced toward our goals. Within the IT enhancement piece, certainly ensuring that data is available that speaks to the demographics of the population that we serve, extremely critical when we talk about having an appreciation of disparities, but also ensuring that the data is timely, accurate, and complete such that we can leverage that information going forward. Just an overview in regards to the goals and objectives fitting within the aims. As we mentioned, aim 1 is to improve health services and the experience of our beneficiaries. Goal 1.1 is to improve access to health. This first objective at the time of submission was still relevant, may still be, but we know this has been placed on hold right now, but it was to note the increased number of enrollees in the waiver program, the pathway program, be it through the time frame of the quality strategy moving toward 2023. The second objective is to increase the number of ladies that receive appropriate and timely postpartum care visits and achieving a target above the HEDIS 50th percentile by the end of calendar year 2023. And HEDIS is a healthcare effectiveness data information set. The National Committee of quality assurance as the steward of those measures. And you hear us reference that quite a bit as far as targets or data sets that we utilize within our quality structure. Increase the number of children receiving well-child preventive visits, critically important for improving health status above the 50th percentile, again for HEDIS. Increasing the number of adults receiving well and preventive visits above the 50th percentile, also for HEDIS. And increase the percentage of membership getting needed care to perform at or above the 67th percentile by the end of the calendar year noted. Goal 1.2 under the first aim, increasing wellness and preventive care. Increase the percentage of children above the age of 21 receiving preventive oral health services. This is the core measure set that CMS is the steward, achieving at the 75th percentile. Increase the overall immunization and vaccination rate across all age bands above the 90th percentile. Increase the number of screenings, be it for breast cancer as well as cervical cancer, achieving above the 75th percentile for both by the end of calendar year 2023. Goal 1.3, improve outcomes for chronic diseases. Increase the number of members with controlled hemoglobin A1C, a blood test that allows insights of whether diabetes may be controlled well. We like to achieve that at the national 50th percentile. Decrease annual hospitalization rates for heart failure at the 75th percentile for the core measure sets. And also increase the number of members with controlled high blood pressure, which we know is extremely prevalent in the Southeast, and Georgia is no different. Achieving a target above the 50th percentile by the end of 2023. Improve maternal and newborn care. We consider this an imperative within the quality strategy. Decreasing the maternal mortality rate by 3% by the end of 2023, and decrease the number of live births with low birth weights, that is 2,500 grams or less, at or above the 75th percentile by the end of calendar year 2023. Goal 1.5 under the first aim, improve behavioral health outcomes, decrease annual readmission, 30-day readmissions for our beneficiaries above the 50th percentile. Increase the number of adolescents that are screened for follow-up for depressions above the 50th percentile, and also adults that are screened and receive follow-up for depression above the 50th percentile by the end of calendar year 2023. Goal 1.6, the member experience. Increase the annual CAHPS overall rate of how families or individuals rate their health plan by 5% by the end of the calendar year. And CAHPS stands for the Consumer Assessment of Healthcare of Providers and Systems. Moving to the second aim, how we are good stewards of resources, smarter spending, increase appropriate utilization of level of care. How can we ensure that, be it through good access, good preventive care, that inappropriate utilizations of ERs don't take place or decrease, as well as decreasing hospitalizations? We hope to perform at or above the 50th percentile by the end of calendar year 2023. Effective medical management, and how can we strive to increase use of other modes of care delivery that was seen so significantly during the public health emergency with telemedicine. Clearly is needing to establish a new baseline in light of that uptick, but building upon what we've seen with the health emergency, hoping to increase by 10% utilizing that modality, particularly in medically underserved areas that have been identified by the end of calendar year 2023. And finally, the third aim of the home community-based services, as well as long-term support services, improving health and services for that population, the goal being improve health and well-being of persons receiving community-based services, increasing the number of waiver participants receiving timely follow-up post-hospitalization visits by 3% by the end of calendar year 2023. Now that takes us through the aims, the goals, and the various objectives. Wanted to give you just a little insight that there was opportunity for feedback from stakeholders in the process. We received feedback from beneficiaries, members, families, advocate groups, medical specialties and associations, healthcare community, as well as other stakeholders within the process. Feedback that ran the gamut of giving insight in regards to feedback about the priorities that we had identified, as well as the populations that are served, insight in terms of the aims and goals and objectives, thoughts as it pertains to improvement projects, and goals and targets, suggestions around potential interventions, as well as the evaluation of how the evaluations of how we might reduce health disparities. So again, it was very good feedback, particularly around the advocacy groups that we certainly reviewed and took into consideration before our final submission to CMS. So where are we on a timeline? We started the process, as we mentioned, under the leadership of Dr. Beecher in the middle part of September of 2020. We had finalized a draft and posted for public comment the first part of March of this year. There was a 30-day period for stakeholder input that was received and reviewed, and we submitted the final product for review by CMS at the end of May. It sits there at this point in time awaiting their feedback and approval, hopefully coming in the near term. I'll stop there. I know I went through a lot. I want to afford the committee the opportunity to ask questions if there are any at this time.
Thank you, Dr. Holloway. That was an excellent presentation, and obviously, again, a lot of work. And I think the areas that you're focusing on in terms of improving access and how we can use our dollars most effectively, are key strategies for healthcare in our state and in our country today. Are there any questions from our committee members for Dr. Holloway? So I'll ask, what is the typical process now that we've submitted to CMS? So it's been a couple months. What is the typical timeline where we hear feedback? What do we expect to hear from CMS pending their review?
I would hope that it would be.
So this is Lynette.
Lynette. I'm sorry. Go on, Lynette.
No, you're fine, Dr. Holloway. We were probably about to say the same thing, which is that we hope it's soon. Generally they take about 90 days to review, documents that we submit to them. One thing to keep in mind, and we've even had to remind ourselves of this at DCH, is I think everybody's kind of recovering from a backlog due to the public health emergency. And so, they being CMS, are working through that right now, and they're clearing some things out, but we're hoping to hear back very soon.
And what does that typically, will they typically say, great plan, looks like you're on target, or, you know, you may want to focus in this area, or have you considered these other things? What do we expect?
Sure, Mr. Williamson. First and foremost, they are going to start with whether your plan addresses all of the requirements that CMS has that a quality strategy must address. And we utilize a toolkit that is essentially a checklist. That would be their starting point, whether we included every element that there's an expectation that they have of us.
Okay.
Then after that piece, it's more in terms of advisory recommendations. If there are thoughts that they've seen elsewhere in other quality strategies that they feel may be beneficial for us to consider. But that's our understanding of how that feedback would occur, Mr. Williamson.
Okay. And then do you have, there's a lot of metrics and measures here. Do you utilize any sort of dashboard type of tool to track our performance on, you know, kind of where we are today and how we are proceeding towards the goal for each of these metrics across the three aims?
Sure, and that's very important question, considering how important visualization is to be able to track and follow, as well as accountability tools. We have just in the process of publishing, and I think Lynette pushed out to you, Mr. Williamson, a quality or CMO quality dashboard that we are moving forward towards, hopefully being public real soon on our website. It includes some key quality measures around a quality pillar structure, very similar to what we're using here around quality, access, stewardship, and service excellence. That's our first starting point of creating visualization tools, not just for consumers, but all stakeholders, internally as well as external. Also within the quality strategy, the lists, and it's a plethora of them, it is our every intent to be able to track those measures ongoing as relates to the objectives as well as the interventions. The interventions may change if deemed appropriate through the course of the time frame, but the ultimate objectives, we will track that as well as have dashboard tools to follow them as well. Not up and running as of yet, but they will be. They will be, and it will be tracked along on an annual basis as they come in compared to baseline as well as ultimate targets.
Well, and if it's within the purview of this committee, I think once that dashboard is put together, that would be something that would be helpful for us just to, you know, when we meet, just to kind of look at that dashboard to see, you know, how are we proceeding, you know, are we red, are we green, are we having any challenges with all of the aims and goals within this plan. And then also perhaps maybe in future meetings, just picking some of these and maybe spotlighting some of the good work that's going, you know, all of these are going to require, as you say, intervention strategies, et cetera, but maybe spotlighting some of the work that's going on, just so that we do a little bit of a deeper dive and understand, you know, how the metrics aren't moving themselves. It's requiring work, and just maybe understanding that a little bit more over time. So any further questions or comments for the committee for Dr. Holloway? Excellent presentation by our Deputy Executive Director. Is there any further business for our committee today? That was our last agenda item. Okay, hearing none, I again want to thank everyone for attending this morning. I think we got a great update on the integration of the MCOs. There's also really good understanding of the quality plan that's been submitted to CMS. And we look forward to meeting again in 3 months. We will adjourn. Thank you.
Thank you.
Thank you.